Hello, I'm Ziad Ghazal from the Division of Cardiology. This is the lecture on cardiomyopathies. To put it simply, cardiomyopathies are disease affecting the heart muscle. There was an old classification of cardiomyopathies whereby cardiomyopathies were classified as dilated or hypertrophic or restrictive or the arrhythmogenic right ventricular dysplasia, and there were the unclassified cardiomyopathies. But this classification is old and has been replaced by a more recent classification from the American Heart Association in 2006. Cardiomyopathies are a heterogeneous group of diseases of the myocardium associated with mechanical and/or electrical dysfunction that usually exhibit inappropriate ventricular hypertrophy or dilation and are due to a variety of causes that frequently are genetic. So notice how the emphasis is on the fact that cardiomyopathies are diseases affecting the heart muscle, either in terms of a mechanical or in terms of an electrical type of dysfunction with frequent genetic basis. But the thing that we need to remember is that, again, based on the American Heart Association statement, cardiomyopathies either are confined to the heart or are part of a generalized systemic disorder. So we have to think the heart and beyond the heart when we deal with cardiomyopathies. And these cardiomyopathies often lead to cardiovascular death or progressive heart failure related disability. Even though until today we tend to use the term cardiomyopathy a bit casually, even with known cardiovascular cause, but that classification that I'm referring to from the American Heart Association in 2006, and even from the European Society of Cardiology in 2008, pathologies with a known cardiovascular cause, such as hypertension, valvular heart disease, congenital heart disease, and coronary ischemia, are excluded from the term cardiomyopathy. So even though sometimes we say hypertensive cardiomyopathy or ischemic cardiomyopathy, in theory, based on the latest classification, we should exclude these type of known cardiovascular causes from the cardiomyopathy classification. So this most contemporary classification of the cardiomyopathies that I'm referring to, which is from the American Heart Association 2006, divides the cardiomyopathies into the primary cardiomyopathies, those that involve predominantly the heart, and there are the secondary cardiomyopathies, those that are that come with systemic manifestations. The primary cardiomyopathy, as you see on this slide, is divided into three types. The genetic type, which as examples, you have the hypertrophic cardiomyopathy, ARVD, or arrhythmogenic right ventricular dysplasia, LVNC, or left ventricular non-compaction, glycogen storage, conduction defects, and the important mitochondrial myopathies and the ion channel disorders. All of these have genetic subsets. Then you have the mixed cardiomyopathy, which comes in the form of either the dilated cardiomyopathy or the restrictive cardiomyopathy. And then you have the acquired, again here predominantly involving the heart, such as the inflammatory or such as viral myocarditis, stress provoked, uh, what we refer to as the Takotsubo syndrome. You may have heard of it, um, or also called the broken heart syndrome, peripartum cardiomyopathy, tachycardia-induced cardiomyopathy. And there is the infants of insulin-dependent diabetic mothers type of acquired cardiomyopathy. Then you have the secondary causes of cardiomyopathy, whereby the cardiac involvement is part of a systemic condition. You have different etiologies, such as autoimmune or inflammatory. One good example is sarcoidosis, diabetes mellitus, infectious, such as the human immunodeficiency virus, uh, viral, such as Coxsackie, Epstein-Barr, parvo adenovirus, infiltrative disorders, such as the amyloidosis, neuromuscular storage and storage disorders, glycogen storage disorder, muscular dystrophy as examples, nutritional deficiencies such as kwashiorkor, and the toxics such as alcohol and some chemotherapeutic agents. For the purpose of today's presentation, I'm going to give you only 3 or 4 examples. I'm going to highlight those examples. One of them is the sarcoidosis, and one other is amyloidosis from the list of secondary causes of cardiomyopathy. And from the primary causes of cardiomyopathy, I will elaborate on 2 disorders, the hypertrophic cardiomyopathy and the dilated cardiomyopathy. So let me first turn to the first example of cardiomyopathy that I want to highlight, the hypertrophic cardiomyopathy. Although hypertrophic cardiomyopathy was written about over the years and known as idiopathic hypertrophic subaortic stenosis, or IHSS. Sometimes we even refer to it as asymmetrical septal hypertrophy, as ASH. This has been going on for really a long time that we've been using these type of nomenclatures. But these terms have been replaced by hypertrophic cardiomyopathy because the segmental hypertrophy can occur in any segment of the ventricle, really, not just the septum. So we've really moved away somehow from the terminology idiopathic hypertrophic subaortic stenosis or asymmetric septal hypertrophy, although you will see it used from time to time. Furthermore, this entity can present without subaortic obstruction to flow, as I will explain to you, yet still carry the same ominous risk of arrhythmogenic sudden death and many of its clinical symptoms. Hypertrophic cardiomyopathy, you need to remember that it's the most common genetic cardiovascular disease, and it's caused by a variety of mutations that are associated with hypertrophy of the left ventricle. It is the most common cause of sudden death in young people. And note that 60 to 70% of cases are familial with an autosomal dominant, mutations. Hypertrophic cardiomyopathy, it is best to separate them into the obstructive, which is the most common, which means it causes obstruction through the left ventricular outflow tract, and the non-obstructive, meaning there is hypertrophy, but it is not causing obstruction in the outflow track of the left ventricle. This is an example of a hypertrophic ventricle where on the left side you have a normal uh, heart where you see the ventricular wall is normal. On the right you see this hypertrophic ventricle where you appreciate the thickness of the septum and of the left ventricular wall. And in the obstructive type of the hypertrophic cardiomyopathy that I referred to in the previous slide, that is caused, the obstruction is caused by mid-systolic obstruction of flow through the left ventricular outflow tract caused by the thickness at the base of the septum that you see here, but it can also be caused by the what we refer to as systolic anterior motion of the anterior mitral valve. We refer to it as SAM, S-A-M, or systolic anterior motion of the mitral valve moving towards the septum. It causes sort of a Venturi effect, but this movement towards the septum during systole, together with the thickness of the septum, causes an obstruction to flow, which will cause a murmur and which will manifest itself also into some symptoms that I will describe to you. There are different morphologies of hypertrophic cardiomyopathies, as you see on this slide. And I'm showing here the most common morphologies in hypertrophic cardiomyopathy. The degree and distribution of hypertrophy is very variable. You see here, for example, that on the two on the left, the septum is thick, and it takes a different form. On this slide, the frequency and distribution of the different form is shown up top. For example, the frequency of the sigmoidal type is 40 to 50% of the hypertrophic cardiomyopathies. You have the reverse curve, also hypertrophy involving the septum, but it takes a different shape than the sigmoid curve. The frequency is 30 to 40%, for example, in this example here. Apical hypertrophic cardiomyopathy, where most of the thickness is in the apex of the heart, and the neutral one, where it's more sort of a concentric type of hypertrophy. Because hypertrophic cardiomyopathy is primarily a genetic disease, you see here on the slide the yield of genetic testing for each morphological subgroup. You see this here at the bottom. Note, for example, that the reverse curve hypertrophic cardiomyopathy, there is a yield of 80% in genetic testing. Now, depending on the morphologic abnormalities and the severity and extent of hypertrophy and the degree of hypertrophy, patients with hypertrophic cardiomyopathy can develop left ventricular outflow tract obstruction. They can develop diastolic dysfunction. They can develop myocardial ischemia, mitral regurgitation, and of course, ultimately, they can develop systolic dysfunction. Now, of all the different forms that I am showing on this slide, the ventricular septal thickness form predominates with the sigmoidal curve or the reverse curve. And these may cause left ventricular dynamic outflow obstruction. As I will detail for you in the subsequent slides, you can, for example, provoke the obstruction or cause a murmur to change dynamically, for example, by having the patient perform a Valsalva maneuver. Notice also that the systolic pressure gradients in the left ventricular outflow tract, you can find those systolic gradients during resting conditions in approximately 1/4 of patients without even resorting to provocation by, let's say, a Valsalva maneuver or uh, other ways to provoke that gradient. So what are the histologic changes that you see in a hypertrophic cardiomyopathy? You see, and this is very typical, you're going to get asked this on questions in several exams that you will be taking. Histologic changes consist of myocyte hypertrophy and disarray, typically, and the expanded extracellular matrix is typically composed of interstitial and replacement fibrosis. And there are different, grades or different degrees, I should say, of myocyte hypertrophy and disarray or extracellular matrix and fibrosis. So this is an example on the left of a normal myocardium where you see small nuclei and you see normal myocytes all kind of running in parallel. On the right, you have an example of a hypertrophic cardiomyopathy with myocardial hypertrophy. You notice how the myocytes are hypertrophied and the nuclei are enlarged. And here you have some regular raid with slight interstitial fibrosis. In this example, again here in the first example labeled A up top, you see hypertrophic myocytes with enlarged nuclei that are again here regularly arrayed with slight interstitial fibrosis. But in panel B, you notice how the myocytes are sort of in disarray. And in C, you see a good amount of interstitial fibrosis, as noted by this asterisk. And in D, you notice how the fibrosis is also involving the endocardium. What is the clinical presentation of patients presenting with a hypertrophic cardiomyopathy? First of all, keep in mind that the presentation is very variable, and not variable only from patient to patient, but variable for the same patient along a timeline clinical course. In general, patients with obstructive disease tend to have worse symptoms and worse prognosis. Remember, we said there is the obstructive type and the non-obstructive type. So those who are obstructive tend to have worse symptoms and worse prognosis because of the obstruction, and the non-obstructive follows a more benign course from a survival standpoint. Many patients remain asymptomatic, but the disease typically can present with dyspnea, fatigue, angina, palpitations, presyncope or syncope, and symptoms are typical of end-stage heart failure may ultimately set in. What are the major causes of death in patients with hypertrophic cardiomyopathy? The most feared complication is sudden cardiac death, and there are certain criteria that we use in order to assess whether the patient is at risk of sudden cardiac death, and those patients typically would receive an implantation of a defibrillator device. Heart failure is one of the major causes of death once patients really dip into heart failure, and stroke is another major cause of death. Now let's talk about the murmur, the dynamic systolic crescendo decrescendo murmur of the hypertrophic cardiomyopathy. One general concept that I want you to understand is that the murmur intensity can be increased or decreased by specific maneuvers. And those maneuvers will basically affect either the preload or the afterload. So the murmur intensity is augmented when you reduce the preload or you reduce the afterload. So always think of it as preload and afterload. Any maneuver we will talk about, think of how it's affecting preload or affecting afterload. The intensity is augmented by reducing preload. Think of it also as such. When you reduce preload, such as when you make the left ventricle smaller, such as when the patient stands up and the blood pulls down, and therefore venous return is reduced and the left ventricle is smaller, it is logical to think that when the left ventricle is smaller and the septum, let's say, is already hypertrophied, part of the basic disease, then the left outflow tract is smaller and the intensity of the murmur is therefore higher. Okay? The intensity of the murmur, on the other hand, is reduced when you have increased preload or increased afterload. So when you raise the leg of the patients, you increase the venous return, and therefore you increase the return to the heart, you increase the volume of the left ventricle, therefore you basically separate or you basically enlarge the left ventricular outflow tract, reducing the murmur. So now, in terms of this dynamic auscultations, there are maneuvers that can cause a higher intensity of the murmur, meaning this causing the obstruction to be worsened or enhanced, and there are maneuvers that will lower the intensity of the murmur when the obstruction is attenuated. What are examples of maneuvers that will increase the intensity of the murmur? And I can assure you that over the next few years, in any exam you take, cardiac exam you take, you're going to be asked a question or two on these type of maneuvers. Higher intensity can be caused by Valsalva. Again, the Valsalva maneuver can pool blood in the lungs, reduce venous return, meaning it reduces preload and it will augment the murmur. Standing from a supine or sitting or squatting position. So when you stand, again, you reduce venous return, reduce left ventricular volume, therefore make the left ventricular outflow tract diameter smaller and augment the murmur. Post extrasystolic potentiation, once you have a ventricular extrasystole, the period after the extrasystole is the murmur is potentiated. If you administer nitroglycerin, again, you reduce the preload, therefore you augment the murmur. In terms of lowering the intensity with attenuation of the obstruction, this occurs from uh, sitting from a standing position or using a hand grip. If you use the hand grip, if you ask the patient to form a tight fist hand grip, what are you doing? You are increasing the afterload. And notice what we talked about here, the murmur is reduced if you increase the afterload. And another example that I mentioned before is passive leg raising. Why? Because you increase the preload in this example, increase the left ventricular volume, and you attenuate the murmur. So this would be an example of a systolic murmur in hypertrophic obstructive cardiomyopathy. You see how the intensity of the murmur gets worse after Valsalva maneuver or standing, as we mentioned in the previous slide. And after rapid squatting, the murmur is reduced. Squatting, basically you tighten your muscles and you increase afterload with squatting. This is an example on the echocardiogram where you see the left atrium and left ventricle here. Notice how, and this is the right ventricle, notice the thickness of the septum, very thick septum, typical of hypertrophic cardiomyopathy. This is another example of an echocardiogram um, where you also see this left ventricular cavity is right here. And you see the intraventricular, not only the intraventricular septum is thick, but here you see that the posterior left ventricular wall is also very thick. This is an example of an EKG of a patient with the apical variant of hypertrophic obstructive cardiomyopathy. Remember, I showed you a few slides ago that there could be thickness particular to the apex of the heart. This is an example of one of those apical variant, also referred to as Yamaguchi syndrome, where the cardiac apex is abnormally thickened. It results in diffuse T-wave changes throughout the precordial lead and sometimes referred to as those giant T-waves. How do we manage patients with hypertrophic cardiomyopathy? First of all, patients need to be kept optimally hydrated. Again, when patients are dehydrated, the left ventricular volume is reduced, the obstruction is increased, and this is added, the murmur is made worse. You don't want to increase the degree of obstruction, you want to reduce it by optimal hydration. Patients cannot stay without some prescribed well thought of exercise and diet in order to maintain fitness, but they should definitely avoid athletic competitions because it does put them at a heightened risk of arrhythmia and sudden death, especially when they have a very thick ventricle. For example, reaching the septum reaching 30 millimeter. That would be actually quite advanced. Asymptomatic patients typically do not require medications, but once the patient is symptomatic in terms of dyspnea, for example, then beta blockers are first line in obstructive disease. What are other pharmacologic treatments? So here, whether it's beta blocker or calcium channel blockers, what you're trying to do is reduce the heart rate, reduce the contractility, so that you make the ventricle pump less vigorously, increase your diastolic filling period so that you fill your chamber better. That would help you reduce the murmur intensity. So again, intensity of the contraction of the left ventricle increases the murmur. You reduce this intensity by reducing the intensity of contraction by using beta blocker or non-hydropyridine calcium channel blockers. These are also reasonable even for the non-obstructive form because they help relax the ventricle. Examples of non-hydropyridine are verapamil or cardiazem, diltiazem. Disopyramide can also reduce resting and provocable gradient. You use diuretics very judiciously as needed. You can, and in certain situations, because if you use diuretics inappropriately, you can dehydrate the patient and obviously worsen the situation, as we explained before. In terms, when you have symptoms that are refractive to medical therapy, then in the septal type of cardiomyopathy, which I told you was the most common type, where there is when the septum is very, very thick, then you consider reducing the thickness of the septum. How can you do that? Either surgically, where the surgeon opens the heart and cuts through the muscle and takes a part of that septum out, called myomectomy, to reduce the thickness of the septum, causing the obstruction. Or you can do it, you can refer the patient to a specialist, interventional specialist, where invasively, percutaneously, the first or second sept or one of the septal perforators that are supplying this septum with blood is actually injected with alcohol, actually, regular alcohol, to basically cause an infarction in that septum and basically reduce the thickness and reduce the obstruction. Family counseling is very important, remember, because of the genetic basis of the disease. So first-degree family members of an affected individual should be evaluated. And because of the risk of sudden death, as I mentioned before, you can refer your patient based on certain selected criteria in high-risk subset. You can refer the patient for an implantable cardioverter defibrillator. Now let's turn to the topic of restrictive cardiomyopathy, and I'm going to discuss with you two diseases which are the most common, amyloidosis and sarcoidosis. In general, what are the etiologies of restrictive cardiomyopathies? The infiltrative type in adults, there are two representative disorders. The most common is cardiac amyloidosis, which I will elaborate on, and less commonly hemochromatosis. The inflammatory type, the cardiac sarcoidosis. You have treatment-related cardiotoxicity, such as myocardial fibrosis caused by mediastinal radiation, and that's, it's the most common type of treatment-related cardiotoxicity, in addition to chemotherapy-induced cardiomyopathy. And you have connective tissue disorders as an etiology of restrictive cardiomyopathies, and you have other etiologies that I'm not listing on this slide. So now let's turn to cardiac amyloidosis. Amyloidosis, first of all, owing to the complexity and multi-system involvement, physicians need to have a high index of suspicion. But first of all, amyloidosis is a disease in which abnormal protein builds up in the body's organ, including the heart. So it most often is a multi-system disease. There is an abnormal folding of a protein rendering it insoluble, and amyloid deposits, as we said, could be systemic and involve multiple organs such as the heart, the skin, liver, kidney, eyes, lungs, nervous system, resulting in a variety of clinical manifestations. Amyloid fibril deposition or deposits in the extracellular space of the myocardium is what causes the pathologic basis of cardiac amyloidosis. Now remember, because of the complexity of the multi-system involvement, physicians need to have a high index of suspicion for amyloidosis and its diverse presentation, and especially in patients who present with heart failure and preserved ejection fraction. The other day, I had a patient present with episodes of palpitations, episodes of syncope. The echocardiogram was very suggestive of infiltrative disease, namely amyloidosis, but the patient also had typical polyneuropathy and GI symptoms, all related to systemic amyloidosis. This is how the pathology looks like. You see here the left ventricular wall, the septum and left ventricular free wall that is very thick. You notice on the endomyocardial biopsy where you have amyloid deposits surrounding each cardiac myocyte. So you see the deposit around the myocyte. This is in contradistinction to the hypertrophic cardiomyopathy that I discussed before, where you have where the myocytes and the nuclei sizes are increased. But this does not happen in amyloid heart disease, where you basically have amyloid deposit surrounding cardiac myocytes. There are two of the most common types of amyloidosis. The ATTR amyloidosis. Most patients with ATTR amyloidosis have a heterozygous mutation and autosomal dominant inheritance. And there is the light chain amyloidosis, one of the also most common types of cardiac amyloidosis, referred to as AL amyloidosis. It's a type of plasma cell dyscrasia. Most cases of AL amyloidosis are associated with a benign monoclonal cardiomyopathy. What are the presenting signs and symptoms? Typically, patients present like the patient I described to you a little while ago. Actually, one of the main presenting symptoms was, in his case, fatigue and weakness. You could also have patients present with symptoms of congestive heart failure, such as dyspnea with exertion or peripheral edema, hepatic congestions and ascites when there is predominant right ventricular failure. Those patients are prone to conduction system abnormalities. They could have left any type of bundle branch block or atrioventricular block. These are frequent in amyloidosis, and they are also prone to develop atrial fibrillation. They could present with syncope or presyncope due to these arrhythmias. They could present with pericardial effusion and even cardiac tamponade, and even ischemic stroke. And the polyneuropathy could occur when the nervous system is involved. What do you actually see on an echocardiogram? You would see thickened left and right ventricular walls. You would see a non-dilated, typically, especially in the initial course, you would see a non-dilated ventricle that is stiff and poorly compliant, thick, stiff, non-dilated, poorly compliant. But because it's thick and stiff, you get progressive diastolic filling abnormalities, But with time and in severe and advanced disease, you will start uh, noticing systolic dysfunction, and the patient would slip into systolic heart. The hypertrophy on imaging represents amyloid fibril deposition rather than myocyte hypertrophy or hyperplasia that I described to you with the hypertrophic cardiomyopathy. So there is no myocyte hypertrophy or hyperplasia, and that's going to be a board question. On the contrary, the problem is not in the myocytes or the nuclei of the myocyte, but it's in the amyloid deposition that occur outside the myocytes. Because of that, the EKG voltages are decreased rather than increased. So this is again a differentiating point. You can see by echocardiogram thickness both in amyloid and in hypertrophic cardiomyopathy. But the EKG, they go in opposite direction. In hypertrophic cardiomyopathy, the EKG, you see increased voltages, while in amyloidosis, you see decreased voltages. So please remember that. You do diagnosis as required. Rarely do we have to resort to a cardiac myocardial biopsy. Abdominal fat biopsy is easy to do, although the yield is not that great. And there are, especially because it's mostly a systemic disease, you go after a biopsy that you would think would have a highest yield in a particular patient. Genetic studies can also help identify the type of amyloidosis. The classic hallmark of cardiac amyloidosis is represented in this EKG, where you see atrial fibrillation and you see low voltage, especially in the limb leads. You see the pseudo-infarct patterns that you see in the precordial leads. And on echocardiogram, again, typical thickness, okay? It has this, what we refer to as ground glass appearance. Again here, both hypertrophic cardiomyopathy and amyloidosis will have this thickness in the myocardium, but one with a low voltage on the EKG, which is the amyloid, one with a high voltage on the EKG, which is the hypertrophic cardiomyopathy. You tend to also see in amyloidosis biatrial dilation and thickened mitral and tricuspid valve. Treatment includes management of cardiac symptoms and treating the underlying amyloid disease, as well as addressing extracardiac amyloid clinical manifestations. The cardiac symptoms, you would treat them regularly, as you would with patients who present with heart failure. And there are several current and future pharmacotherapies for AL and ATTR amyloidosis, which I will not go into today. Now let's turn to cardiac sarcoidosis. Cardiac sarcoidosis is a multi-system disease of unknown etiology. And remember, it manifests as non-caseating granulomas. Because it is a multi-system disease, predominantly it involves the lungs and intrathoracic lymph nodes. In systemic sarcoidosis, approximately 1/4 of patients can involve the heart. So you have cardiac sarcoidosis in approximately 1/4 of patients with systemic sarcoidosis. Cardiac sarcoidosis most commonly involves the myocardium, but it can affect any part of the heart. And similar to other involved organs, cardiac disease generally progresses from areas of focal inflammation to scar. So we have two things to distinguish. One is inflammation, and the other is scar. When you have scar, it's too late to do anything to reverse, but when you have inflammation, immunosuppressants can reverse focal inflammation, and that's the mainstay of treatment in cardiac sarcoidosis. Um, in terms of systemic sarcoidosis, the clinical manifestations depend on the extent of core organ involvement, which could be dermatologic, pulmonary, the eye, uveitis, etc. A minority can remain asymptomatic and are discovered incidentally on imaging studies, such as a CT scan. So patients go for a CT scan for whatever reason, and are found to have, for example, lymphadenopathy, which is pursued, and then sarcoidosis is discovered. Pulmonary complaints are seen in about half the cases. Systemic complaints such as fever and anorexia are seen in also about 45 to 50% of cases. This would be a schematic representation of how the sarcoidosis affects the heart. It's typically patchy. Amyloidosis is global. It involves all of the myocardium, but sarcoidosis is patchy. That's also another distinguishing feature. Here, for example, you have fibrosis in the septum and the free wall of the left ventricle. It can manifest as heart block, heart failure, supraventricular arrhythmias, and ventricular tachycardia, two re-entrant circuits around the scar. So, in a nutshell, cardiac sarcoidosis involves the myocardium in a patchy way, and clinically and typically it manifests as heart block. So the first presentation could be a patient coming in with complete heart block, or it could present with heart failure or arrhythmias. And the symptoms include palpitations, presyncope, syncope, fatigue, dyspnea, orthopnea, and sudden cardiac death. In terms of diagnosis, imaging to check for areas of inflammation or scar, what can we resort to? Echocardiography initially may be normal, just showing normal myocardium, normal valves, but in advanced cases, it may reveal focal areas of akinesis or wall thinning or aneurysms due to scar. Cardiac MRI, on the other hand, can show areas of inflammation or scar. In fact, the MRI will not be able to distinguish between scar or inflammation. It will show you delayed hyperenhancements in the involved areas of the myocardium. However, between inflammation or scar, you can resort to a rest perfusion imaging, which can show scarred area, or a very resorted to test is the PET FDG, which can really show areas of inflammation. And it's important to know whether these areas are present in order to help the patient go through the proper treatment, which is primarily immunosuppression. Biopsy of extracardiac sites may provide a higher lead. So take a patient who gets a CT scan for some reason, but incidentally is found to have lymphadenopathy. It's biopsied and shows, let's say, extracardiac sarcoidosis. So that would be one way to make a diagnosis. And as far as cardiac biopsy, it's not really advisable because the disease is patchy. So the endomyocardial biopsy has a lower yield. And in terms of management, you should address potential disease manifestations. Then Holter monitoring is important to see if the patient is developing any type of arrhythmia, because remember that those patients are at risk of potentially lethal arrhythmia causing sudden death. Immunosuppressive therapy such as steroids, methotrexate, Cellcept are within the armamentarium to reduce inflammation and to help reduce the risk of progressing to scar. Of course, you manage conduction abnormalities and ventricular arrhythmias as they come. Patients who present with complete heart block will receive a pacemaker. Patient at risk of developing lethal ventricular arrhythmias will receive an implantable cardioverter defibrillator. And of course, you manage heart failure with heart failure therapies. Now let's turn to the last topic I want to highlight within the cardiomyopathy, which is the dilated cardiomyopathy. Here you have an example of a normal heart on the left, hypertrophic cardiomyopathy in the center, where you have excessive contraction and impaired relaxation and a thick, typically thick wall, specifically more commonly the thick septum. In a dilated cardiomyopathy, you basically have, you don't have a thick heart, but you have a dilated ventricle with a poor contractility. The etiologies include ischemic cardiomyopathy. Now, I'm using the word ischemic cardiomyopathy, even though I told you at the beginning of this presentation that we really don't resort to this terminology based on the latest classification from the American Heart Association. But we kind of, even when we use it, we need to remember that it's not a term that's supported by the classification system, period. What is the most common cause? Coronary artery disease. That's the more common cause in the United States. So it's not forbidden to use this term, ischemic cardiomyopathy. You can use it, but just remember that it's not supported by the most recent classification, AHA 2006. Other etiologies include alcohol and chemotherapy. There are also etiologies such as myocarditis, such as viral cardiomyopathy. Idiopathic cardiomyopathy, dilated cardiomyopathy, 50% of them have a familial disease, so you have to look into that. You typically have dilation of one or both ventricles with impaired contraction. So dilation with systolic dysfunction. The presentation, typically patients present with symptoms of heart failure, most commonly fatigue, reduced exercise capacity, dyspnea with exertion, orthopnea, PNDs, and peripheral edema. The presentation could be incidental, could be an incidental finding without symptoms of heart failure. So let's say you're just working a patient up for any reason, and you get an echocardiogram and you see a dilated ventricle with a reduced ejection fraction, but the patient has yet not developed any symptoms. Patient can present with other related symptoms such as arrhythmia. So to conclude, I have given you a sort of a quick overviews of the cardiomyopathies, which are a heterogeneous group of diseases of the myocardium that are typically associated with, as we said, mechanical or electrical dysfunction, and usually exhibit inappropriate ventricular hypertrophy or dilation. And remember that they are due to a variety of causes that frequently are genetic. Remember also that cardiomyopathies could be confined to the heart or could be part of a generalized systemic disorders. But cardiomyopathies often lead to death, cardiovascular death, or progressive heart failure related disability. And of course, I will discuss with you presentation and managements of patients with heart failure in different presentations. Thank you.